Welcome to the first in a short series of lectures about the large intestine and the radiography thereof. Over the course of these lectures, I'm going to be using these abbreviations, so as you come back and study, these will be the things to look out for as far as that goes. As we talk about the large intestine, the objectives are going to be to understand the different modalities we can use in terms of radiography and contrast radiography, really, to evaluate the large intestine, understand what the large intestine is supposed to look like, and then understand what the large intestine is not supposed to look like and common appearances for some of the more common diseases of the large intestine. We're going to talk a little bit about kind of a general workup approach, and then over the span of the lectures talk about intermixed normal appearance and abnormal appearance of the large intestine in various disease states. So we're going to start with the general workup. And the first thing to think about is what sort of bad things can happen to the colon. One thing is it can change its ability to move fecal material through it. That may be increased or decreased transit times. It can become obstructed, and that can be due to some sort of object within the lumen. It can be something from the wall or outside the wall compressing it. It may rupture, just like any other part of the GI tract. And then finally, you can have an abnormality of the mucosal architecture and the function such that there's changes in absorptive capacity, which is obviously something we're not going to be able to evaluate very well with most imaging, same as the rest of the GI tract. We get concerned about the colon as a possible cause of clinical signs when we see diarrhea, when we see constipation in a patient, straining to defecate. Any sort of abdominal pain could roll back to the GI tract. Ultimately, you have to evaluate the whole patient because certainly a number of diseases can be present. It doesn't have to be the colon even with one of these clinical findings. So when you see diarrhea, there are a ton of differential diagnoses to think about, everything from diet, including dietary indiscretion, to foreign objects, to inflammatory diseases or neoplasia of the colon or small intestine. So lots of different things can go on. Again, notice on the right-hand side, you've got various diseases that aren't primary GI diseases at all. So a ton of differentials for diarrhea, only some of which affect the colon or directly involve the colon. Same story with constipation or tenesmus. Again, many of these are directly affecting the colon, but some of them are a secondary bystander. Again, you have dietary problems. You can have obstruction from inside or outside, whether that's pelvic fracture or the prostate or a foreign object, neurologic disease. So again, a lot of these diseases are certainly affecting the colon, but may not represent a primary disease of the colon. So ultimately, our goal in radiography is to identify when the large intestine is affected by some sort of disease process. Again, recognizing that radiographs are not going to be great when it comes to identifying colonic inflammation or ulcers or other mucosal disease. That's really not going to be the primary goal here. We want to be able to identify constipation. And a lot of times we have a pretty good idea of that going into radiographs because of the clinical history and the patient's clinical signs. And then we also want to be able to identify any sort of structural abnormality that may be causing a problem. Is there a mass outside the colon compressing the colon? Is there a mass of the colonic wall? Is there a stricture or a torsion? And not all of these are going to be directly identified with survey radiographs. You may need contrast radiography to really get your final answer here. Nonetheless, survey radiographs are always a good place to start because you might get the answer. You can certainly look for masses if they're big enough, whether they're outside or extending into the colon. You may be able to see them with radiographs. And depending on what you see, you may have a good idea of what to do next. And that next thing might be a pneumocolonogram. And that's where we administer gas into the colon. We can use that for identifying who the colon is if we're trying to sort out if there's a small intestinal foreign object versus an object in the colon. But it's also good for identifying the mucosa of the colon to look for a mass, for example. And then the positive contrast colonogram is kind of the other way one might do that in a radiographic setting. We're not talking about ultrasound here, but a barium enema, again, you can evaluate the wall and the mucosa, good for finding a mass, good for finding stricture. So a very useful technique as well. As with other parts of the GI tract, if you have reasonable concern that there might be a colonic rupture, you should use iodinated contrast medium rather than barium in case of leakage, because ideally we won't have barium in the peritoneal space because that does lead to granulomatous peritonitis. So we're going to go through some cases kind of as we go here. Here's a normal colon. It's a positive contrast colonogram or a barium enema, and you can see that there's nice filling of the entirety of the colon all the way up to this corkscrew-shaped cecum. There's the Foley catheter with the balloon filled with gas, so very nice appearance. You see a few small filling defects, a couple little gas bubbles, that's normal. A tiny bit of fecal material, that's okay too. One thing that's interesting, I've highlighted in yellow, there's a little loop-de-loop here, which is some redundant colon, and that's not uncommon, certainly not clinically relevant. Again, filling defects representing normal things in this case. Here it is on the ventrodorsal view, same story. You can see normal descending colon. It has some redundancy to it in this case where it kind of, again, does this little hairpin business. That's okay. It is just a variant of normal. I referred to ultrasound previously. It can be useful when you're looking for wall masses. Not as great for strictures, but sometimes you can identify a stricture with ultrasound. The problem is going to be that you're not going to be able to see through fecal material and gas in the colon, and so seeing the deep wall may be a challenge depending on what's in the lumen. CT is a good way to evaluate the wall, but it's not as available. Colonoscopy is also a great way to evaluate the mucosa and get biopsies of the mucosa, but you're not going to see the deeper parts of the wall with colonoscopy. So all of these modalities are useful, but they do all have their limitations as well. So now we'll move forward into part one, sort of the normal appearance of the colon, and then some principles of interpretation for various diseases. First thing we'll think about is the location and shape of the colon. Normally the cecum is located in the mid-abdomen on the right side. We don't usually see it in cats, but in dogs it'll have kind of a reverse C shape on the VD view, or corkscrew shape, kind of a coiled spring shape, all those things. Most of the time in dogs it will have gas in it, not 100%, but the vast majority of the time it will be gas-filled in a dog. The colon broadly has the shape of a question mark on the VD view, although we saw with that redundant colon that's not 100% true. And then the descending colon enters the pelvic inlet where it connects with or turns into the rectum. Again, redundant colon is when the colon's longer than it needs to be, but it really has no clinical consequence. So here we have a normal dog with a relatively normal colon. This one's fairly gas-filled, so it stands out really nicely on these survey radiographs. There's a little bit of fecal material, a little bit of mineral material in the colon here, but mostly a nice gas-filled colon. And you can see that the cecum is easily seen right here in the mid-abdomen on the right, and then you can see the ascending colon, transverse, and descending parts of the colon, which I will highlight there for you. Again, it's kind of a question mark. You may have to use your imagination in some animals. On the lateral view, obviously it's not a question mark. We're seeing it in a different plane. Here it's still gas-filled. There's where the cecum lives, again, mid-abdomen. Most of the colon lives in the same plane, just dorsal to or even superimposed on the cecum. And ascending and transverse colon may kind of loop up here dorsally. It depends by patient in that case. Another normal colon, again, it's gas-filled, makes it nice to see. A little bit more redundancy on this one. The nice cecum here, reverse C, and then kind of some loop-de-loops as we have ascending to transverse to descending colon. Again, no real consequence as to the formation there. Just recognize that that's a normal variant. And then here it is again on the lateral view. Yet another normal. Here we have a cat with some redundant colon. This one has more fecal material in it, so you can see the short ascending colon. It's normal in a cat, it's not very long. Transverse and then descending, and it actually loops all the way over to the other side where the rest of the descending colon is more on the right side. It's uncommon that we see that, but it's not necessarily abnormal. Sometimes it means there's a mass pushing it around, but a lot of times we see that it's just because there's a big bladder that's kind of pushed it to one side or the other. So again, just presence of the colon on the quote wrong side doesn't inherently mean you have a problem here. And as I mentioned before, we don't see the cecum in this case because we usually don't see it in a cat. When there is a change in the shape or location of the colon, mostly that's going to be due to something outside the colon shoving it. So often some sort of mass, could be a herniation if the colon is pulled through a hernia. But usually it's something that is secondarily affecting the colon rather than a mass or something primarily of the colon. And so then it becomes important to think about what sort of objects or what sort of structures live all around the colon and all the parts. And so here's kind of a schematic of a ventrodorsal view. Remember, you've got mesenteric lymph nodes in the center, and then there's kind of where the colon and cecum go relative to all these other organs. And so you can see abnormalities of the liver, of the spleen, of the kidneys, of lymph nodes, of the bladder. Any of those could affect the colon, could push the colon to one side or another. On the lateral view, we see that as well. It's a little tougher to sort out in the cranial abdomen sometimes, but certainly as you get to the caudal abdomen and pelvic region, you can definitely see displacement of the distal descending colon and rectum. And so again, you have to think about what sort of structures live in those places. So if the colon or rectum are ventrally displaced, you think about these lymph nodes dorsal. If there's dorsal displacement of the colon and rectum such that it's up against the spine, you start thinking about urogenital structures as being the source. Prostate is certainly a big one in dogs. So here's a dog with prostatic carcinoma, also has metastases to medial iliac lymph nodes. And what I see here is, for one thing, the cranial part of the descending colon is very ventrally displaced, but he's a pretty fat dog. So that may not be abnormal in this case. That might be all right. But what really draws my eye more is as I come back here toward the descending colon and toward the rectum, the colon is ventrally displaced a little bit more than I'd expect from the spine, but it's also quite narrowed. And dorsal to it, I see this soft tissue mass, and ventral to it, I see this soft tissue mass. And then I see a lot of reaction of the spine there. And so again, this is a dog who has prostatic carcinoma with metastases to the nodes and to the spine in this case. And so there's our colon. The bladder's not very exciting there. The excitement's all coming from caudal to that. And so we have these structures that are compressing the colon, the very distal descending colon, and that's lymph nodes here in that medial iliac lymph node region, and then the mass itself, which is the prostate in this case. Here's a patient who had perineal swelling, and on the survey radiographs here we have a lateral view. I can see the colon running down to the rectum. So far so good. It looks pretty empty. And then there's this very odd gas and heterogeneous soft tissue opacity back here, sort of partially in the plane of the rectum and anus, but it's really extends well beyond what I would expect for a normal appearance of those structures. And so that's probably the source of our swelling. And on the VD view, we see a similar thing where I can see a little bit of the descending colon up here. As I get back to the rectum, if I see fecal material, I would certainly expect to see it on midline because that's where the rectum lives. And in this case, I see what looks like fecal material, but is definitely off midline, which is definitely not where it belongs. And so in this case, this was perineal herniation of part of the rectum. It had shifted to the side, or again, a part of it had herniated out to the right side. One location/shape abnormality that is a primary disease of the colon is colonic torsion. And you'll hear this as torsion or volvulus. There are slight differences in the definition of torsion and volvulus. The torsion is the twisting of an organ along its long axis, just like you're wringing out a washcloth, and that causes an obstruction, versus a volvulus where there is rotation of the organ along its mesenteric attachment. And so the vessels twist, you end up with ischemia, and that's a functional ileus. There's not actually an outflow obstruction at that point. So mild differences in what is actually happening, what is actually twisting. A lot of the times we don't necessarily know in the colon what it is. So many times I would say that it is a torsion, but I think sometimes it's a volvulus. And so when it comes to the colon, these two terms are kind of used interchangeably. It's probably not appropriate to do that, but that's the way it is. So either phrase is probably okay enough. In any event, it results in the colon being in an abnormal position. So in this case, the entirety of the colon may all be on the right side of the abdomen. For example, you see the ascending and the transverse and the descending all on one side of the abdomen. That would be weird. And so that would raise your concern. Most of the time, the colon is going to be distended with gas, certainly that portion of the colon that's proximal or orad to the twist. And then it usually has a weird shape, maybe an interruption in the gas. It's really gassy, and then all of a sudden you can't follow it anymore. That's a problem. Barium enemas are really useful in these cases to get your definitive diagnosis because these are surgical emergencies. These are cases who are sick and have a problem and are going to need to go to surgery sooner rather than later. So here's a relatively typical appearance of a colonic torsion, at least as much as they have a typical appearance. And what we see is a very large, distended, gas-filled intestinal segment. And it certainly could be that we have two populations of small intestine here. You've got distended and non-distended, but it's kind of a weird spot for small intestine. It's very much more dorsal and more cranial than most of the small intestine, where I expect to see more mid-ventral. So that makes me think that this might be colon, but we have this disconnect in that we have this large bit of colon, which is in a little bit of a weird position even for colon, and then all of a sudden it really tapers down, and then the descending colon and rectum back here are more fluid filled. And so it's a little bit weird how we have this abnormal sort of combination of two parts of a large intestine. But it's certainly not definitive on the basis of this lateral view, so I want to see the ventrodorsal projection. Again, there's your parts for your notes. On the ventrodorsal view, it's even weirder looking. Again, we have what could be two populations of small intestine by having distended and non-distended, but really all of the small intestine looks like it's in the right spot, and where I see the distended segments, it's all way off to the side, which is very unusual for small intestine, making me think it's large intestine. Additionally, it has the path of large intestine, at least partially, and there's about the right amount to be plausibly descending, transverse, and ascending. It's just kind of looped on itself, a kind of one could imagine twisted over on itself. And then again, given that amount of gas in the large intestine, I don't see anything back here where I would expect to see the most distal part of the descending colon or the rectum. So given those findings, this is a strong candidate for a colonic torsion. And so this abnormal case is almost certain to have a colonic torsion because that's just what I talked about, and is a big dog, so I had to stitch together the two radiographs. And what we can kind of see is that we've got, at first glance, two populations of intestine, because we have a lot of gassy ones, but we have some that are kind of medium distension, not too distended, and then we have some more cranially that are a lot bigger. The problem is we don't know at this point who's small intestine and who's large intestine. On the VD view, it was still a bit challenging to tell, so we decided that the next thing to do was do a barium enema, and we did. And so we put this positive contrast agent into the colon, into the rectum and into the colon. You can see the catheter running through right there, and what we see is that there's this kind of twisting and narrowing of the colon to a point, and then there's no contrast that gets back or gets forward any further. And so this is a colonic torsion. The colon has twisted on itself, and so thus almost certainly all of these larger loops up here are actually colon, cranial or orad to the obstruction that's this twist. And then again, you get the impression that there is actually a twisting of the lumen there. So this dog needs to go to surgery. The important thing to remember on colonic torsion, even though it's important to try to make that diagnosis, this is a tough diagnosis to make. These are a lot of times pretty tricky. And so you have to have it on your radar. You have to think about it. You know, is the colon shifted for some other reason? Is it a mass effect? Is it redundant colon? Or might this be a colonic torsion? The big clues are going to be some clinical clues, i.e. the animal's really sick. If there's a mass pushing the colon, usually those animals are not shocky, whereas in the case of colonic torsion, they usually are a lot sicker. The other thing is to radiographically look and see where is that colon. Again, is it all on one side of the abdomen? Because it really doesn't all belong on one side. Even with redundant colon, it kind of crosses back and forth. So if the whole colon is all on one side of the abdomen, that's a concern. And then if part of the colon is really gassy and really distended, and then all of a sudden you can't find the rest of the colon, that real disconnect, that should clue you in that there may be a torsion there as well. So that'll bring us to the end of this part of the colon. We'll move forward with part 2, where we'll go through a few more normals and abnormals.